Good morning. Good morning, everyone. Shujasan. Today, I'm going to present the topic virtual neurocognitive testing in craniofacial surgery. And this article is just published this month in Plastic and Reconstructive Surgery. And as for introduction, as we know, digital communication platforms are now popular for both personal use in social media and as a professional platform in plastic surgery. Like for example, in cranial synostosis research, social media was used for nationwide genetic testing of patients with non-syndromic cranial synostosis. And this genetic analysis together was correlated to functional impairment using neurocognitive tests. And due to the limitation by the number of patients available for the study geographically, virtual neurocognitive testing was developed as a facsimile of in-person testing to gain access to a larger patient pool. So in this article, the author presents the technique for a complex neurocognitive test through a telemedicine platform and a preliminary comparison of results to in-person testing. And so for the patients and methods, for the neurocognitive tests, there are three tests are included in this article. And we can see the table 1 below. The first is Westerler abbreviated scale of intelligence. And the second one is the Kaufman test of educational achievement. And the last one is Sperry Botanica development test of visual motor integration. So all of these tests and surveys used in this study were selected by a child psychologist or a psychiatrist. And these tests were previously published for use in cranial synostosis assessments. And the test involved complex block pattern building and verbal face-to-face assessment and visual motor skill tasks. And these tests took a minimum of 2 hours. And here for the virtual neurocognitive test, as we can see the picture on the right side, here is a package, and there's a blue board is applied and tapped to the table to allow proper orientation of the camera and allow accurate assessment of visual spatial tasks and block building. And another webcam here is provided to allow an overhead view of the table for a direct visual assessment of tasks. And other instructions, consent assent forms, and testing paperwork and testing items such as block are also included. So on agreement, the family were provided with this package, and consent assent was granted virtually through an institutional review board approved verbal consent pathway. And then it will conduct a 2-hour virtual neurocognitive test session. And after the test, the family would then repackage the items and return to the equipment. And as for a comparison of in-person and virtual testing, and according to individual test guidelines, there is a minimal interval of 6 months was recommended for between 2 tests, the retesting, to ensure valid results. And a cohort of 10% who were initially tested in person were selected for virtual retest. And after completion of the study procedures, a 7-question survey was administered virtually to the patient and their parents or guardians to access the ease of this digital system. So for the results, first is demographics. A total of 10% participated in this study and 2 were female. And all patients had a history of deformational plagiocephaly in infancy, and none of them had a history of surgery to the scalp, severe head trauma, seizure, or learning disability. And repeated virtual testing was performed an average of 377.3 days after initial testing. And participants were on average age 7 years at initial testing and 8.8 years at follow-up testing. And here comes the testing results. As we can see, all the items between 2 groups the first is initial test and the retest, and another is retest groups. All of the test results show no significance in these two groups. All the p-value were above 0.05. And these items included verbal IQ, performance IQ, full-scale IQ, layer and word recognition, math computation, reading comprehension, spelling, reading composite, and visual motor integration, visual perception, and motor coordination. And as for the survey results, as we can see on the right side, there is a questionnaire containing 7 questions, and it's dispatched virtually to the patients and their parents or guardians. And the results show the median time taken to set up the research study equipment was 5.0 minutes. And all 10 families found participation in the virtual research study to be somewhat easy or very easy. And 70% of the participants preferred to participate in research from home. So the discussion is, the author found high fidelity between live and virtual neurocognitive testing, which with no significant differences between the two methods in scores of all categories. And given that the participants had been out of school for 3 to 4 months because of the COVID-19 pandemic, so the academic achievement in the previous table show there's a non-significant drop in the retest group. And for the survey results confirm or an overall positive experience and preference for research studies by means of webcam. And our sample virtual neurocognitive testing was derived from the cohort of deformational plagiocephaly patients without any diagnosed learning disabilities or developmental delay. So given to this inclusion criteria, this modality can be generalized to patients without non-learning disabilities or diagnosed developmental delay. And so performing this test in a cohort of patients exclusively with learning disabilities would be helpful in the future. And another concern regarding online tests is the technique learning curve. But on review of this experience, there was little difficulty teaching parents or patients, with the average workspace preparation time under 10 minutes. However, this study is limited by a small sample size. But the author considered that the only 10 participants was selected is in order to minimize unnecessary testing, as it is potential burden for these young patients to participate in 2-3 hours test sessions. And so, in conclusion, this study presented the technique of virtual neurocognitive testing with preliminary results showing comparability with in-person testing. And that is the article I shared today. And is there any question?
Yes. The audience, do you have any questions for this paper? I think this paper is one to tell us the feasibility of the virtual neurocognitive test and in-person test have the similar result, and they all both could give us very high reliable, probably the reliable or significant test. No matter once you attend the meeting in person or you can have the test online, right? Is this the final result of this paper?
Yeah, yes, the author considered that virtual testing can have the same results with in-person test.
But however, all the participant is only limited to the 10 patient, and they were all both without any congenital anomaly. They are all belong to the deformational plagiocephaly, right? Okay, so it is believed they are all very good IQ and EQ performance. Mm-hmm.
Yes. Yeah, so the author put emphasis on that perhaps this virtual testing should be only conducted in neurodevelopment delayed patients.
Okay. Okay, may I have asking Professor Lu? Yes. I'm not sure this kind of neurocognitive testing is performed in the synostosis patients or in the brachiocephaly patient. Is any differences for their result? Mm-hmm.
Hello.
Yes.
So, hi. I just wondered, in this paper, the virtual neurocognitive testing, is it just online meeting with a specific person, like a psychologist, or is a like automatic question for the patient, or is that a real psychologist to do the testing online, or you know?
Yeah, and the author, there is a person-to-person interaction session during the session, but the author, the article did not mention whether the person is a professional psychiatrist or psychologist.
So the difference of the in-person or virtual is just online or not online, right?
Yeah, yes.
Okay. Because I just discussed with the psychologists, they prefer to do the like testing, like psychologic testing in person, because they probably think it will be better understand of the meaning of the patient. So I think this article is quite interesting, because if the patient can do like online, maybe the psychologists they don't need to be in the like clinic. They can be at home to do the psychological questionnaire to the patient. But I'm not sure if the craniofacial patient can have the same result.
Okay, I have one question for Dr. Lu. According to the Likert scale, I'm not sure what is the Likert scale of the maybe 1 to 5 or 1 to 10. Which one is much better for the tester? For example, here is only 8 to 10, 7, 8, or 9. So what the complexity of the Likert scale is good for this kind of patient with this age?
I don't know the answer.
Okay, it's a little difficult. Okay, so I would like to invite Professor Low to comment on this paper. Yes, thank you, Professor Low.
Well, I think that the so-called online visit, clinic or evaluation follow-up may become more and more popular in the future. Until now, I still feel uncomfortable to see patient online. But maybe this is the beginning of our, so-called online visit. Maybe in the future it will become more and more popular. We just have to prepare for that to happen. And yeah, I think the most people, the comment is that this test is for the so-called brachiocephaly without synostosis, but it really is a minor neurocognitive deficit. The difference between online and in-person may not be the same. So this is the issue of this article. Thank you.
Okay, thank you, Professor Low. Is there any more questions for this paper? Okay. If no, thank you, Dr. Jiachen Xu, for your presentation. Okay, and then we proceed to the next paper. The presenter is Dr. Lan Jinyu. Okay, Dr. Lan, please.
Okay, good morning, everyone. Can everyone see the slide now?
Yes.
Okay, let's start the second journal reading today. And good morning, Professor and dear colleagues. I'm the 6th-year resident, Lan Jingyu. And today's second journal reading today is refining orthognathic surgery result by synchronous cheek fat compartment augmentation with fat grafting in adult females with a classic 3 skeletal profile, which is, now this paper was published on PRS journal last year. Actually, it's from one of our previous fellow, Rafael, and our Professor Johnson Xin. Okay. The orthognathic surgery managed the abnormal maxillomandibular relationship for malocclusion patients. And however, after the correction of the maxillomandibular disharmony, there's the residual or new facial contour irregularity from facial may become more evident. And in order to enhance the surgical outcome and patient satisfaction, there's several concomitant or stage procedure have been proposed, such as modification in osteotomy line and the bone segment repositioning, rhinoplasty, facial implant placement, and facial soft tissue contouring. And here's the preoperative and postoperative frontal and profile views of a patient who underwent orthognathic surgery without fat grafting. And we can see the anterior medial cheek region seems still a little bit insufficient. So in this article, the authors put focus on the synchronous orthognathic surgery with cheek-specific fat grafting and measure the effect on facial appearance and the mid-face volume and the position. This is a prospective study from 2016 to 2018, and including around 20 consecutive adult Taiwanese Chinese female patients, which were all underwent a surgery first approach with a 3D computer-assisted two-jaw orthognathic surgery technique by a single surgeon, and with the this OGS is synchronous with the cheek-specific fat grafting, and this for the correction of the skeletal castry deformity and the concave mid-face. The facial photograph and the combing CT were obtained preoperatively and postoperatively 12 months. And another comparison group, including 20 adult patients who also underwent the orthognathic surgery, but without the fat grafting, were also included and adjusted for matching factors such as the sex, ethics, and the facial pattern to compare with our consecutive patients. And there's both a subjective and the objective assessment as outcome measurement in these studies. The preoperative and postoperative 2D frontal and profile views were randomly distributed and rated blindly by 12 plastic surgeons and 30 lay persons. The evaluation including the 3 facial appearance scales, including the beauty, attractiveness, and the pleasantness. And for the objective measurement, the author used the anatomical landmark reference plans and superimposed the preoperative and postoperative 3D facial bone and the soft tissue models. And here's the 3D facial models, including the postoperative soft tissue and the green one, and the postoperative postoperative bone models superimposed on the corresponding with a preoperative model. And we can see after the superimpose these two images, we can see the frontal, the forehead region. There is actually no much deviation before the preoperative and postoperative. That's we can see the accuracy is quite good for this superimposition. And here's a 3D mid-face soft tissue model were constructed by the intersection of the bone and the soft tissue derived planes. And this bone and soft tissue derived planes also define the region of the anterior medial cheek area. And this 3D facial soft tissue model display the reference planes adapted to isolate the region of the anterior medial cheek. And from this cheek, we can see the 3D mid-face soft tissue volume change around this area. For the bone-derived plane, including the Frankfurt plane, mid-sagittal plane, and the lephoromaxillar plane, and for the soft tissue-derived plane, including the lateral mid-face plane, lateral nasal plane, and also the horizontal nasal plane. And three-dimensional mid-face volume change, which shows the in pink and purple color area here, was calculated as a postoperative result minus the preoperative result in soft tissue 3D imaging. And here is the cheek mask position. The 3D cheek mask position was calculated to represent the most projected point on the cheek contour. And it was defined by measuring the horizontal distance between a cheek mask point and mid-pupillary plane, Frankfurt horizontal plane, and the cornea perpendicular plane. And for the results in this table, we can see a synchronous fat grafting group and the non-fat grafting group. And both of these two teams were further separated into preoperative, preoperative, and post-operative condition. There's no significant difference in maxillary advancement or the clockwise rotation between synchronous fat group or the non-fat grafting group in OGS surgery. But we can see with the fat grafting, the synchronous group had a significant larger change in facial appearance related to perception scale and the mid-face volume, as well as the postoperative cheek mask position. And there's actually also measure the healthy female individual for the cheek mask position. We can see the healthy female individual with the cheek mask position is 2.19 and with 1.3. And which is more similar to the group of the synchronous OGS with the fat grafting groups, and significantly larger than the isolated OGS group. So for the discussion in these studies, the author evaluated the outcome of the orthognathic surgery with the fat grafting using the panel assessments and the 3D image matrix. With or without the fat grafting, OGS bring the significant beneficial effects on facial appearance, including improvement of the facial appearance related perception, and so as well as the volume and the sagittal position change in the anterior medial cheek. But with the facial grafting, there's a more significant mid-face volume change than without the fat grafting. And there's a more significant postoperative cheek mass position change with compared with without the fat grafting group, and also have a better facial appearance change in orthognathic surgery with the fat grafting group. The anterior medial cheek region is an important element to consider when planning our orthognathic surgery. And in this study, they recommend including, in addition to consider the occlusion and the lower face elements, we should also make the patient-specific preoperative diagnosis and operative plan, contemplating the facial aesthetic characteristics, including contour, balance, proportions, and the symmetry of the facial contour and the boundary. And another point of this patient is that the attribute of the facial fat tissue permit that orthognathic surgery with fat grafting not only enhance the mid-face volume, but also produce a smooth transition of the nasal mid-face and the malar mid-face region, and blended with the lower eyelid and cheek junction. And there's also the potential reduction of the postoperative edema. In conclusion, synchronous orthognathic surgery and the cheek-specific fat grafting result in a superior enhancement of the facial appearance and mid-face volume and position compared with isolated OGS without fat grafting. And from this image, we can see a preoperative and postoperative profile views showing the correction of the maxillomandibular disharmony and the improvements of the anterior projection and the contour of the anterior medial cheek region after the fat grafting as well. And this volume enhanced procedure achieved the more attractive convexity of the mid-face region from lower eyelid to the lower face, and the smooth transition of the nasal mid-face and the malar mid-face zone, and the more symmetrical anterior medial cheek area. Okay, and here's the today's second journal reading. Is there any question?
Thank you, Dr. Lan. Okay, so I would like to invite Professor Chen-Xin Chang. He is also the corresponding author of these papers to give us the highlight of this paper. Thank you, Professor Chang.
Yes, thank you, Dr. Lan, for the presentation. I think it's not surprising that we see from the lateral facial profile in patients with class 3 malocclusion, they have very depressed mid-face. And for depressed mid-face, the lower part, so-called deep nasolabial fold, is easily corrected with PD-form area advancement, and you can see the improvement in this area. However, the upper part, including the tear trough deformity and just below the tear trough, is depressed, and the patient easily look like darkness, dark circle, and they look tired, they look older, and some of the patients even look they never get sleep because of the dark circle and the color mismatch. The idea comes from some of the patients after the surgery. This area became swelling, and it became better because the depressed area after swelling, it has improved appearance. So in the initial, I just put some fat grafting over there, and I noticed that the patient is very, very grateful because the dark circle disappeared, the harrow in the depressed area improved, and especially they look younger and much beautiful. So let's come from this study. And it's surprised that the survival rate of fat grafting after OGS is better compared to the ordinary fat grafting patients. And well, I was very surprised, and I asked myself why, and looking for the answer. And one day Yoshimura did a study. Normal baric oxygenation improved survival rate. Hyperbaric oxygenation will decrease the survival rate. So I started thinking that our patient after orthognathic surgery, the first 3 days, they receive normal baric oxygenation, plus they do not tend to move their mid-face. They have a mask-like face, immobilization. And I cannot prove that, but because we do the osteotomy, maybe some migration from the mesenchymal stem cell from the bone marrow is close to our fat grafting area, and the stress-induced mesenchymal cell is the term they use for the nano-fat. And we know the stress-induced and the mesenchymal cell will multiply. So I study and showing that the survival rate is better and the patient satisfaction rate is better. So right now, all my patients who receive orthognathic surgery, especially for class 3, will have mid-face augmentation. Thank you.
Thank you, Professor Chen's comment. So I have one question for Professor Chen. When we doing the OGS, we focus on the mid and lower face. Of course, the upper face, forehead, or the temporal area is not being moved in orthognathic surgery. So I think I have a good probably because they are not moved, so unchanged, we could easily predict the result of the fat grafting. But I'm not sure once you want to put the fat for the mid face or low face, as well as the orthognathic surgery, what is your predictability for your final result in your experience? Yes, please, Professor Chen.
I always do the marking before the surgery. I think it's like a Sidney Coleman. If you see his video or his presentation, he always mark precisely before the surgery. In orthognathic surgery, especially the mid-face, temporal frontal area, I always mark before the surgery. And I think that is a very good habit. Once you mark precisely, in your mind, you know how many millimeter that you might need it. And another point is Dr. Li from China. Currently, he's living in US, and he published a paper that the volume needed for every subunit of facial in each person. I think we should stick in our plan. That means you know how much millimeter were needed in each area in average person. For example, in mid-face, I average put 1.6 millimeter to 2.0 millimeter for average person. I think if you stick to those two plans, I think should be fine. The only problem with fat grafting in OGS is lower face. I have been questioned by the reviewer, but since our anesthesiology, that they lower the blood pressure, and if you really take a look, our patient after surgery, the swelling is still just fine, not too much. And I think still feasible to put fat grafting in the lower face if you still see some deficiency. Thank you.
Thank you, Professor Chen. Later, I would like to invite Professor Low. Would you like to execute the simultaneous fat grafting on the cases of the OGS as well?
Well, I actually learned from Professor Zhang that in addition to the main operation OGS, there are several other things that we can do to improve the facial appearance. Certainly for patients with class 3 prognathizant concave face, when I design the OGS, I usually try to do clockwise rotation of the maxillomandibular complex, try to increase the mid-face volume. But sometimes, if I do too much rotation, I could, retrude the mandible too much. So in that situation, I think this will be a good solution that with adequate clockwise rotation and I do some fat injection to the mid-face, I think to change the mid-face from concave to convex appearance is quite important for patients in this group. But I think the most important that we learned from Dr. Zhang is that we should always bear in mind that when you do any kind of reconstructive procedure, we need to think of something else to improve, to enhance the facial aesthetic outcome. Not only the fat injection, but also the nose augmentation or double eyelid procedure, or even some like Botox injection. So combine the procedure is very helpful. This is what I learned from Professor Zhang. Thank you.
Okay, thank you, Professor Low. Dr. Chief Yao. Okay, instead of the fat grafting for the augmentation of face, do you have experience to remove the buccal fat pad, or do you have any experience to once you do the OGS as well as to rearrange of the fat on the face? Yes, Chief Yao.
I do. Most of the time I only select the asymmetry case, and if I predict that only skeletal only will not result in a good symmetry, I will consider doing fat injection at the same time. So my experience only limited to severe asymmetry or hanging facial microsomia patient.
Okay, got it. Thank you. Okay, is there any questions for Dr. Lan and Professor Chan in this paper? Okay, if no, I think we can conclude these meetings. Okay, thank you for your participant and have a good day. See you. Bye-bye.